because it is very important to do a risk assessment for any patient going for major abdominal surgery, because otherwise the risk of deep venous thrombosis with major surgeries as high as 17 to 40%. And it is particularly high in the first 12 weeks. And if you ask of, the greatest risk is in the first 6 weeks. Now, what is HAT? HAT is hospital-acquired or hospital-associated thrombosis. It is defined as any venous thromboembolic event which occurs when the patient is in the hospital or within 90 days of hospital admission. And it accounts for 50 to 60% of all thromboembolic events. Now, coming over to how does OHSS affect the risk of thrombosis? This is a question again. Which of the following is true about OHSS following IVF pregnancy? So yes, 100-fold increased risk of VTE in pregnancy is achieved by IVF if it is complicated by OHSS. And in case the patient has severe OHSS, thromboprophylaxis, and she gets pregnant, so thromboprophylaxis should be continued till the first trimester. This is again, which is true. And then in case the patient doesn't get pregnant, then it should be discontinued. The thromboprophylaxis should be discontinued at the time of withdrawal bleed. So again, this is also true. So the answer here is all of the above. Just covering about the VTE risk in early pregnancy and if there is risk of OHSS. The risk of VTE, it increases from the first trimester and it is attributable to the hypercoagulable state in pregnancy. It is due to thrombin generation, which increases in women as early as 5 weeks of gestation. And it has been seen that there is 100-fold increase in risk of VTE with IVF, which is complicated by OHSS, and as opposed to 5-fold increase in pregnancies with IVF without OHSS risk. So OHSS is one of the major risk factor. And in pregnant patients who conceive after IVF and have developed severe OHSS, then the thromboprophylaxis, it should be continued for the duration of the first trimester. Whereas the females who do not conceive following IVF, then thromboprophylaxis can be discontinued with the onset of the withdrawal. Pathophysiology of thrombosis, we all know about the Warshaw's triad, which is the triad includes anything which can result in endothelial injury, could be because of surgery or inflammation, with stasis of the blood flow, which could be because of immobility or venous obstruction, and a hypercoagulable state, like in cases of cancer, abdominopelvic surgery, any underlying condition, nephrotic syndrome, sepsis, pregnancy, postpartum, thrombophilia, and estrogen therapy. So a combination of all these increases the risk of thrombosis. Now, this could again be asked from the guideline that post-cancer surgery, for how long you should give thromboprophylaxis. So according to this TOG, you should give it for at least 4 weeks. Okay, so cancer, it is a recognized risk factor for VTE. And for cancer patients, you have to give dual thromboprophylaxis, that is both mechanical as well as the medical. And it should be extended for 4 weeks after the pelvic cancer surgeries. Now coming to the VTE risk associated with CHCs or combined hormonal pills or contraceptives. So the risk is quite high, like incidence is around 5 to 20 per 10,000 women years in pregnancy, 40 to 65 per 10,000 and women years postpartum, and it is 3 to 15 per 10,000 in users of CHC. So CHC is again an important risk factor. So when a patient who is on CHC is planned for any major surgery, so ideally the CHC, it should be stopped 4 weeks prior to the planned surgery. And when you're planning to restart it post-surgery, it should be at least 2 weeks. So there's 2 durations you have to remember, that it should be stopped 4 weeks prior and restarted 2 weeks following. Now, coming to other things like a route of surgery, it is seen that risks associated with laparotomy is much more than laparoscopy, and with abdominal surgeries more than vaginal surgeries. And if they ask you that which has the highest risk post-gynecological surgery, so it is if the patient has hip and knee replacement. So that is one of the important risk factor, followed by the cancer surgery. Now, this is again a question which can be asked about mechanical thromboprophylaxis. Which of all of these following are true except? So patient adherence is better with knee length stockings than thigh length. This is true because knee length are more comfortable. Then about intermittent pneumatic compression devices, they reduce the risk of DVT by 20%. So this is not true. Actually, they reduce by as high as 60%. Then the third statement, anti-embolic stockings are contraindicated in the presence of peripheral arterial disease or peripheral arterial bypass grafting or peripheral neuropathy, skin conditions like dermatitis. So this is again true. So the answer here is B. Then coming over to the modes of thromboprophylaxis. So one is just ambulation, the second is mechanical, and third is pharmacological. So mechanical, what all does it include? First one is anti-embolic stockings. Here, like the pressure which is aimed with the compression stockings is around 18 millimeter at the ankle. Again, can be asked one of the questions for your exam. And it is patient adherence, as we've already discussed, it is better with knee length as compared to thigh-high stockings. Regarding pneumatic compression devices, they reduce the risk of DVT by 60%. And in any peripheral arterial or venous disease, anti-embolic stockings are contraindicated. Then regarding comparison between fondaparinux and LMWH, what does the guideline say? According to NICE guideline, although fondaparinux can be used as an alternative to LMWH, however, there are certain issues associated with fondaparinux. One, it has a longer duration of action and doesn't have a reversal agent. Also, the bleeding complications are higher. So this you should keep in mind. Then coming over to comparison between direct oral anticoagulants and LMWH. So direct oral anticoagulants, the examples are apixaban, dabigatran, rivaroxaban, and doxaban. These agents have rapid onset of action and are short acting and are associated with lower bleeding risks as compared to warfarin. They have good safety profiles, and unlike warfarin, they do not require regular blood monitoring. Moreover, we do have reversal agents like for idracizumab is there for dabigatran, and for andexanet alpha is there for apixaban and rivaroxaban. Then what are the conditions where you have to be cautious while using thromboprophylaxis? So there are certain patient-related risk factors and procedure-related risk factors. Patient-related is anything which increases the risk of bleeding, like if there is active bleeding or patient has a bleeding disorder, platelets are very low, blood pressure is very high, patient has acute stroke, or she's on any other anticoagulant. The procedure-related are the procedures which increases the risk of bleeding, or where there are higher risks related to anesthesia, if there is an epidural in place, spinal or lumbar puncture. So again, you need to be cautious. Which has the highest risk of VTE? So this we have already discussed that it is hip and knee surgery. Now, how do you score? So there is this table given in the talk, which you have to learn by heart, because you can get questions giving various scenarios. Like they can give a 60-year patient who is planned for a surgery for any gynecological surgery, like suppose hysterectomy for any reason, and she has a history of hip and knee fracture, hip and knee replacement surgery done. So then if you see for hip knee surgeries, then the risk is quite high. Okay, it is +5. The score is +5 and she is 60 years and +1. If there are no other risk factor, then we have at least the score of 6. Then based on this chart, you plan for thromboprophylaxis. That is, you will have to give LMWH for 7 to 10 days along with intermittent pneumatic compression stockings. And some asterisk points from this table that you have to know that like any surgeries which is occurring during the pregnancy. So the minimum score is +3, and for those patients, any pregnancy surgeries in pregnancy, you have to give LMWH for minimum of 10 days. So this they have put in asterisks. And for cancer surgery, we have already discussed, it should be, the prophylaxis should be given for 28 days. So these two things you have to remember. The first one, any surgeries during pregnancy, you have to give thromboprophylaxis. You have to give during pregnancy, you have to give thromboprophylaxis for at least 10 days. And any like cancer surgery, you have to give thromboprophylaxis for at least 20 days. So this is based on the scoring. You calculate the score based on the table, and then you do the risk assessment and give thromboprophylaxis accordingly. So if the score is 0, then you just allow the patient to ambulate, or you can give mechanical things like intermittent pneumatic compression devices or graduated compression stockings. 1 to 4, moderate risk, again the same thing. 5 to 8, it is high risk. So in this, you have to give LMWH for at least 7 to 10 days along with the mechanical prophylaxis. And if it is more than equal to 9, then you have to give it the LMWH for at least 30 days along with a mechanical thromboprophylaxis. So this is something which you have to remember. Okay, so these are some of the one-liners. You can just go through these. I've already discussed about it in the guideline. So I'll be waiting. You can put the answers in the comment section. And I'll be happy to, in case you have any doubt on the topic which has been discussed, you can post your doubts as well. So in case you like the lecture, please press on the like button, and also do share and subscribe to the channel. Thank you so much. Saranya, it is done. Hello. Hello.
Hello.
Yeah, it is done.
Okay, thank you, dear.
Okay, thank you.
Recording stopped.
Saiza. കഴിഞ്ഞില്ലേ?